Paraneoplastic syndromes is quite important both for undergraduate and postgraduate teaching, and these are common questions that are asked in the exam. Now, there are certain products that are released by the tumor. For example, ACTH is released by the adrenal carcinoma or a lung cancer, and this can cause Cushing syndrome. Hyponatremia can be associated with inappropriate antidiuretic hormone secretion, and this is seen in lung cancers. Similarly, hypothalamic tumors produce vasopressin. Hypercalcemia, hypoglycemia, these are all part of paraneoplastic syndromes which patients experience. In other words, these patients experience endocrine disease and they manifest in the endocrinology department. And sometimes in the early stages, a tumor is not detected because you may feel that the patient is suffering from an endocrine disorder and not a paraneoplastic syndrome due to a tumor. There are many cancers that are inherited, and we call these inherited cancer syndromes. So, heredity plays an important part in cancer regulation. Inherited cancer syndromes usually have a strong family history of cancers, and they're usually autosomal dominant. For example, retinoblastoma, which is familial. Familial adenomatous polyposis of the colon, where the child inherits a defective gene by which the person manifests with thousands of polyps in the colon. Multiple endocrine neoplasia syndromes. There are three types, MEN1, 2A, and 2B, which will be discussed separately in systemic pathology and neurofibromatosis. There are certain autosomal recessive syndromes where, because of a defect in DNA repair mechanism, when a DNA damage occurs, it is not repaired, and this mutation continues cell to cell, and thousands of cells undergo the mutational damage as they proliferate, and that results in a tumor growth. These are some examples of autosomal recessive syndromes. Each is a different disease of its own, which will be discussed in systemic pathology. Now we move on to grading and staging of tumors. Grading is a method by which we microscopically see the tumor and you tell the differentiation, whether it is well or moderately or poorly differentiated or anaplasia. Staging is clinical. You see the progress or spread of a tumor based on a clinical staging. So grading, as I told you in the previous session, depends on the differentiation. So based on the differentiation, it tells you the aggressiveness of the tumor. A grade 1 tumor is well differentiated. A grade 2 is moderately differentiated. A grade 3 tumor is poorly differentiated. A grade 4 tumor is anaplasia. So this is an example of a grade 1, grade 2, grade 3, and grade 4. Staging depends on the TNM system. This is the most common system used worldwide to stage cancers, where T is the size of the tumor, N stands for node, lymph node involvement, and M stands for metastasis, whether there is metastasis or not. This picture is an example of how you would stage a tumor using the lung as an example. T0 is when your primary cancer cannot be detected. TIS is when the primary tumor is in situ. T1 when the primary tumor is less than 2 centimeters. T2 is 2 to 5 centimeters. T3 is more than 5 centimeters. And T4 when it extends beyond the lung. N1 when the local lymph nodes are involved. N2 when the lymph nodes on the other side of the body are involved, such as the contralateral lung. N3 when lymph nodes on the other side of the diaphragm are involved. Metastasis is either M0 when no metastasis or M1 when there is distant metastasis, which means you may have a patient with a T2, N1, M0, which means his tumor size is 2 to 5 centimeters, nodes on the same side, and no metastasis. Or T3, N3, M1, which means tumor more than 5 centimeters, lymph nodes on the opposite side of the diaphragm, and presence of metastasis. So, based on what we have seen, a diagnosis would be made as, for example, this is a case of a lung cancer which is low grade, which is moderately differentiated, and it has a staging of T2, N2, M1, or so on. So this is your diagnosis: squamous cell carcinoma, high grade, poorly differentiated, stage 4 with liver metastasis. So in your diagnosis, you include the cell of origin, the rate of growth, the extent of differentiation, local invasion, and metastasis. To make a diagnosis of tumor, it has to be a combination of clinical, radiological, and morphological methods. So for this, you will have to do a history, clinical examination, and you will need a lot of radiographic support, X-rays, ultrasound, CT, MRI, to help to localize the tumor and to see where the tumor has spread to other parts of the body and to help to stage the tumors. And morphology, cytology, we can use pap smears in the case of vaginal, cervical cancers, fine needle aspiration biopsy, for example, in the case of breast cancers and thyroid cancers, and actual biopsy, where you take the surgical specimen, slice it, process it under a tissue, and look under the microscope and do a histopathology study. And if you feel it's a cancer, for example, a breast cancer, you can use tumor markers, BRCA1 and 2.